let's start with our learning outcome, and to see what is important in this course. What is important is to understand the learning outcomes, to understand the kinematics of the normal and arthritic knee, the importance of soft tissue that we have to consider in knee kinematics and to prepare your total knee arthroplasty, the principles of the 3 axes of the knee, and the key and the knee alignment in total knee arthroplasty principle. We have just to remind you that the function of the musculoskeletal system is to provide control of motion with joint stability, muscle activity, and proprioception. These are 3 elements which are the most important for the stability for any joint. It should be stable. We should have good muscle activity, and the interaction between the stability and the muscle activity, which is the proprioception.
Sorry, Prof, can you make it full screen, please?
It is full screen now?
Yes, thanks.
Yes, okay.
It's full screen.
Yeah.
Yes, sir. Now it's full screen.
Now it's full screen. Okay.
Yes,
perfect.
sir. Yes, sir.
Okay. Then the function of, as I said, it gives you stability, muscle activity, and proprioception. The functional load situation within a walking scheme will change in the gait, the direction of the joint reaction, which is the yellow line, is controlled by the magnitude and the direction of the functional or the ground reaction. This is the opposite, and the magnitude of the direction of the necessary responding, which is the muscle. The muscle responds to stabilize the knee with this red reaction that makes the knee stable. What is a stable joint? Stable joint is one that maintains an appropriate minimum contact of force between the 2 parts of the joint, between the articular surfaces, though the functional range of motion. Once it's stable, the function is good. Then what is important in stabilizing this knee? The location of the reaction forces is correlated. The function of the muscle and the stability of the ligaments and the capsule. This is the most element important that gives you the stability of the knee. When you add it to the congruent surface, articular surface, this is what demands in this study of the importance of the correlation between the cruciate ligament and the function of the quadriceps and the hamstring. This is what is called the proprioception. Cartier's French surgeon demonstrated in 2010 that in flexion of the knee, when you flex the knee, there is a small medial translation to determine the positioning of the femoral, which determines the position of the femoral components regarding the tibial plateau. And when you open the knee, you flex and you extend your knee, you will see a little bit of translation, a small amount of translation of the medial condyle. And this will give you an idea how to center the femoral component in front of the tibia. This stability in flexion extension is given by the correlation of 2 axes in the knee. The correlation between the patellofemoral axis, when the range of motion of the patella in front of the femoral condyle here, and the axis is the point X, and the flexion extension femoral axis. These 2 axes should be exactly parallel to have a knee stable. On the other hand, the flexion extension axis, when you flex your knee and extend your knee, you have an axis on which there is flexion of the leg and extension of the leg. Between 0 and 2, it was demonstrated by Eckhoff in 2013 that this axis is not fixed with very mild activity between 0 and 20 degrees of flexion. When your knee is almost in extension, you have a knee which is a lot not too stable. Between 90 and 20 degrees, which is the angle when you walk, the angle that you use when you walk, this axis became fixed. This gives you stability when you walk and stable to push forward the body, and you need stable knee that to push the body forward, and you have an axis which is stable. After about more than 90 degrees, between 90 and 150 or 155 degrees, this angle is not fixed since we need more laxity. When you kneel on your knee or when you squat, then there is external rotation and posterior translation of the tibial plateau. Then the articular surface, the two fragments between the femoral condyle and the tibia, there is more space, then you need more laxity, then the axis is not very stable. That's why this axis is not. We see in this study done by Scott in 2008, the most important issue, because the knee needs laxity, but to have a fluent walking sheen, you need some laxity in the knee. The knee shouldn't be rigid. If we stress the knee anteriorly, like you do an anterior drawer to test your ACL, for example, when you tract on the tibia forward and you take it up, the tibia comes back to its initial position, and this is laxity. This is something you don't have when you have a knee arthroplasty. With the knee arthroplasty, it is not possible because you have two congruent surfaces in metal and plastic, and there is no more important laxity than you lose in laxity with total knee arthroplasty. But we need some amount of laxity in when you have a knee total knee arthroplasty to make the walking sheen very fluent. Then the locomotor task demonstrated different kinematic patterns, and the muscle activity and external joint loading affect the knee kinematics. That's why when you see the sheen which is on the right side, you see that the axis on the medial tibial plateau, it doesn't move a lot. It's almost the same. On the other hand, when you see on the lateral plateau more you flex and you squat and you kneel, the axis goes back, and it means that lateral tibial plateau is going posteriorly and the femoral and anterior of the tibial plateau. Now there is more movement in the lateral part, and we will explain later on what is this importance of more mobility in the lateral part of the tibial plateau more than the medial part of the tibial plateau. Other factors of this laxity of the knee: articular surface, bone and cartilage thickness, soft tissue, passive and active, geometry coupling determine a patient-specific kinematic. It means more you have cartilage which is thick, then you give when you lose the thickness of the cartilage, the joint becomes more stiffness. Any change of one of the structure belonging to the knee will alter the knee kinematic. When you have loose ACL or you have loose PCL or lateral collateral ligament, you don't have anymore the same kinematics of the knee. The kinematic will change. Any change in the structure of the soft tissue will change the knee kinematics. The change in knee kinematics will affect the articular surface, then determining osteoarthritis. There is more pressure in the medial part, there is more pressure in the lateral part, there is no more, for example, menisci, then the pressure on the articular surface will be more important, and there is abnormal loading pattern. Abnormal tibiofemoral kinematics will affect the patellofemoral kinematics, and then the deformation of cartilage, which reduces the force value. These are all these elements which are integrated, and we have to take in consideration when we think about how the knee is working and how the different elements should be taken in consideration in total knee arthroplasty and not only the bone. An interesting study what have been done by Tanamis and Pavel in rheumatism in 2009, and with other papers by Brewer in 2007, Hunter 2007, and High 2007, shows in systematic review that found only limited evidence for relationship between knee malalignment and incidence of osteoarthritis. It means not all the people that have malalignment of the lower limb should have knee osteoarthritis. But however, there was strong evidence that knee malalignment is an independent risk factor for progression of radiographic knee osteoarthritis. It means if you started your osteoarthritis lesions in the knee with the soft tissue collaboration with the collaboration of tissue, the malalignment will contribute in the progression of osteoarthritis in this condition. Then you have, when you have abnormal kinematics, it gives damage of collagen network in the surface zone of the articular surface. Then when you have collagen network surface zone, you have an increased friction between these two surfaces with reduced compressive stiffness. Then the articular surface, the cartilage will be thinner and it will be stiffer. And this can increase the tangential shear surfaces. There is shear surfaces will be more important, and they increase the shear stress in the cartilage, which is dependent. Then you will have a high rate of progression. Flexion extension axis is the knee kinematic signature. Flexion extension sign is the knee kinematic signature, is the most important one. Patient knee kinematics and kinetics are determined by soft tissue and articular surface geometry, both. Soft tissues, articular surface geometry. Soft tissue envelope affects the kinematic and kinetics more than tibiofemoral alignment. This is by the study we have shown about malalignment of them. Neuromuscular proprioception is coupled with soft tissue envelope and articular surface geometry. This correlation is very important. Then, stability laxity pattern are most important factor for osteoarthritis initiation, and any change in soft tissue and articular surface geometry will alter knee kinematics. Then, after this basic element, we move to the perspective for knee alignment and the goal of the knee alignment. Why? To restore the pre-disease knee alignment with an arthroplasty, whatever it is, uni knee or total knee arthroplasty. We have to restore an anatomic pre-arthritic situation. We have to restore the soft tissue balance and to improve the soft tissue function with better anatomic situation. We cannot restore everything perfectly with the total knee arthroplasty, since we said that it is there are rigid elements, but we have to give the soft tissue to give you the best function that they have to give you good function, and the most important, that the patient should feel almost normal. Then, with the knee alignment, you should know the pre-arthritic situation of the knee. You will plan the HKA angle, hip, knee, ankle angle to have natural aligned knee. You have to maintain the functional soft tissue envelope, as we said, with minimal injury, that not to release everything, not to detach everything, because all these soft tissue are very important for the function of your knee arthroplasty. You have to restore the balance of the muscle function and mainly between hamstrings and quadriceps, and to align the prosthesis in the three planes: coronal, sagittal, and rotation plan. All these elements, you have taken consideration one point which is very, very important. You have to meet the patient's expectation. What is the expectation of the knee, and what is the point that your patient came to you to see you for knee osteoarthritis? How much is the deformity? How much is the osteoarthritis progression? How are the soft tissue? And then what can you give to this patient, and to see if what you can do meet exactly the patient's expectation, if you wanna just to walk and to have just normal life, regular life without any sport, or there is someone who is wanted to do play tennis. There is no comparison between these two patients. If we come back to the history of total knee arthroplasty and people when they started to do total knee arthroplasty in the 80s or 70s, there was they think about the knee as 2D lance correction, and we have to do articular surface with perpendicular tibial and femoral cuts, and 3D of external rotation to balance the flexion and extension gap. But we see later on that a lot of things changed. Changed why? In an alignment that we have 3 axes of the knee to be restored, according to Hollister and study published in the Core 1993, which is the most among the most important paper to read about this subject to research, which is some of these 3 elements. To restore the native tibial and femoral surfaces and thickness, to restore the natively alignment, to restore the native collateral ligament tension, and finally, doing a total knee arthroplasty, it's a research roadmap with a learning curve. It is not only studying the axis, but you need to study the technique, the type of procedures that you are using, to perform a training with workshops or maybe cadaver labs, and see reference trained surgeon to get trained to do your knee arthroplasty. Then we have to prepare a whole strategy for knee arthroplasty. You have to need pre-op Maquet X-ray, AP, and lateral view of knee. Start with the staging technique to understand the role and importance of each stage. Be familiar with the different correction steps, and keep in mind to restore the kinematic alignment. You have to co-align the axis of the joint line of the components with the 3 kinematic axes and the joint line with the pre-arthritics or native knee without ligament release and without placing limits on the degree of the preoperative deformity and the degree of postoperative correction. We know that all what we do on the soft tissue should be revised. Then the axis of rotation of the knee, as we said, the application of flexion extension axis, which are, this is the study of Hollister, of the knee motion of prosthetic design and reconstructive surgery, is profound. This axis is very important. Where is this axis? This is the transverse axis in femur about which the tibia flexes and extends. This axis passes through the center of the femoral condyle, but it is not the epicondylar axis. It is the axis of the center of these 2 circles which shape the posterior part of the femoral condyle through the center of the femoral condyle, and this is the study of Hollister. The second axis is the patellar position relative to femoral epicondylar axis during squatting, and this femoropatellar axis is 10 millimeters proximal and almost 12 millimeter anterior and parallel to other transverse axes for the patella tracking. And finally, the longitudinal axis is the tibia about which the tibia rotates on the femur. This is the tibia. This is the axis anterior and perpendicular to other 2 transverses. This axis is on perpendicular. It was defined by Kallel in 2003. It is not very far. It's 2003. Freeman in the Journal of Biomechanics in 2005, it was almost prophetic. He was described as the axis passing through the center of medial condyle. He enabled medial ball and socket. He was the first to describe the ball and socket description of the tibia and enabled it on the femur. These gave the idea of the prosthesis with the medial ball and socket aspect and lateral unconstrained answers that restore the high mobility and have a high level of laxity. Actually, more of the latest design of the prosthesis are adopting this philosophy, but in a different way. It is not exactly the same way, like the Persona or Atun or Medacta. The team of Medacta is very concerned to this principle of ball and socket in the medial condyle. They took these examples from image from Professor Stephen Howell from Sacramento in California. And these images show that principle of the medial condyle and MRI, we see that it is almost a perfect circle and a socket on the tibial plateau on the sagittal and coronal view. And this MRI, dynamic MRI, explains the movement of the normal femoral tibial joint. And it was described by Freeman in Journal of Biomechanics in 2004. And we see that in flexion at 90, we see that the flexion at 90 degrees is almost stable here. And the lateral compartment in the high flexion, you have an anterior displacement of the tibial plateau and posterior displacement of the lateral condyle. And this gives the idea that the constraint on the lateral condyle shouldn't be important, and we need a tibial plateau with almost without the lip in the posterior part to give the opportunity to the femoral condyle to roll back, and the tibial plateau goes forward to give you more elasticity in the lateral part and of the joint. This is the axis which is on the medial condyle, and we see that more you flex, the femoral condyles run posteriorly and the tibial goes forward anteriorly to give more mobility in the lateral part. On the other hand, on the medial condyle, we still stick to the principles of the ball and socket in the medial part. Then, when you're taking all these elements, how to restore and to do your cut to stuck to the concept of these three axes and restore three axes. Now you have to measure the resection to confirm the femoral component is kinematically aligned. You have to stick to the thickness of the prosthesis that you are doing. Most of the prostheses, they have a thickness between 8 or 9 millimeters. And for this, you need a caliper and just to control and to size the thickness of the cut of the bone and femoral component after adjusting for wear and curve. This is the restoration of normal joint line, and kinematic alignment is confirmed. You have from anterior to posterior the different fragments that you have. This is the anterior here, this one is here, this one is here, and this one is the posterior. You should have almost the same thickness here than here, the same thickness here than here. Then you need a caliper and to see how much is the thickness, and you take in consideration the thickness of the saw, which is almost 1 to 1.5 millimeter that you have to cut. This is how to restore the distal femur, as we said with the MRI. This study was done to know what is the difference between the thickness of the cartilage in the posterior part, and you see the difference here. There is no more cartilage here. You see less more cartilage here, and there is almost typically 2 millimeters more or less difference between worn and unworn zone. Then when you cut the distal part of the femur, measure the distal femoral bone resection here to restore the normal joint line, because you have to restore the pre-arthritic knee. Then you have to give the same thickness that you lose from the worn cartilage, and to bring the same thickness. And to restore the normal joint line, the thickness of the distal resection should be 4 to 5 millimeters on one surface. Then you have no cartilage in this part, and you have 6 to 7 millimeters on unworn surface for an 8 millimeter thick femoral component. You have to add here 1 or 2 millimeters the thickness of the cut of the saw, as we said. And when you measure the posterior femoral bone resection, then you cut an anterior, you cut posterior, and the anterior flange. They are almost the same. The posterior 4 to 6 millimeters on one surface, 6 to 7 millimeters on onward surfaces. But if you have resected a little bit more, if you have resected a little bit more in posterior in one part in another, you have to just to rotate the chamfer here, guys, posterior of the thickness, and to over resect and to fill the gap with the cement. You have 1 or 2 millimeters, then you can over cut, and you have to fill them with the cement to give the good position of the femoral condyle. Then we do not, what we learn from these three axes, we do not cut the distal femur perpendicular to the mechanical axis of the femur, which is in the yellow line here. We don't extremely rotate the femoral component. The rotation will be affected by the size of the cut that we have. We don't align the epicondylar axis. Why? Because when you take references to the study of Eckert in the core in 2007, there is difference between the transverse axis and the epicondylar axis, between the flexion extension axis and epicondylar axis. and doing 3 or 4 or 5 millimeters of external rotation automatically is not good, then these steps change the obliquity and the level of the joint line, which kinematically malalign knee, causing flexion and stability, and actually on the function, it will be resolved by pain in the patient. Then kinematically align a total knee arthroplasty is relatively simple. Just to confirm the full resection after ejection for wear and curve and equal thickness for femoral component to bring back exactly the same pre-arthritic situation. For the tibia, not a lot of discussion about how to cut the tibia because it should be perpendicular to the axis, whatever it is, intramedullary or extramedullary cut. But the most important thing is the tibial slope. The discussion subject in the tibia is how much slope in the tibia. We have demonstrated in study in 2018 by Marco Mara in knee surgery and sports trauma that the reference of the center of the tibial plateau is much more accurate than you take references in the anterior cortex. Your references should be in the center, and this is to calculate your tibial slope. Then changes in posterior tibial slope have considerable effect on knee laxity, kinematics, forces. More posterior tibial slope with anterior cortex references technique increases the knee laxity and flexion, also and extension. More posterior slope with cortex, with the center of the tibia technique, leaves the knee laxity almost uninfluenced, is beneficial for knee extensor apparatus and relieve the pressure of patellofemoral joint. The tibia resection should be pre-planned and executed accurately as possible in this type of cut. And what is very important in total knee arthroplasty, when you plan to put the tibial slope, you have to template on your x-rays the tibial slope that you have and what you expect of your from your tibial slope cutting. Another question with these problems of kinematics on the tibial plateau is non-cruciate retaining, posterior stabilizing, or fixed rotating platform mobile bearing total knee arthroplasty with respect to the different posterior tibial slope. This study was in 2018 into biomedical research. The kinematics of the fixed bearing total knee arthroplasty changed as posterior tibial slope changed, but there was relatively less change in mobile bearing rotating platform total knee arthroplasty. In particular, cruciate retaining, the effect of the tibial plateau slope was the greatest. This suggests that the surgeon should be careful in determining the tibial plateau slope in the in total knee arthroplasty with cruciate retaining. Cruciate retaining is not very familiar, or is very common in our environment. I have visited a lot of our countries, and I know that in North Africa, even in Tunisia, we don't have cruciate retaining arthroplasty. Most of arthroplasty that we are doing are posterior stabilized, whatever it is, mobile or non-mobile tibial plateau. And we see here that confirm always the same thing, that the medial part, the movement of the axis is not very important, and the mobility is much more in the lateral plateau. The other point that we discussed in knee alignment in our discussion in total knee arthroplasty is the patellar resurfacing. Do we restore? Do we resurface or not resurface? This is what is the base evidence in 2020, published in the Journal of American Academy of Orthopedic Surgeons. There continues to be a lack of clear guidelines regarding patellar resurfacing. Anterior knee pain is the most common presenting reporting total knee arthroplasty with or without patellar resurfacing. Although absolute rate knee pain trend to be higher without resurfacing, the difference have to be shown to be statistically different. However, the presence of anterior pain in the non-resurfacing group leads to markedly reoperation with non-guaranteed improvement in the symptoms therefore. Thus, there are some evidence suggesting that functional recovery with patellar resurfacing. Despite this finding, the evidence still lacking till 2020, and for surgeons to continue to using their current strategy, resurface or not resurface now, or selectively resurface. I am from people who are going for selectively research. If you want to do a total knee arthroplasty and the femoral patellar joint is good, I do not research patella, in my opinion, until additional evidence emerges. Given the lower rate of revision surface with resurfacing along with similar or potentially improved satisfaction and functional outcome, while at no increased risk of complication, preference is to resurface all patella for Johannes, but I think that selective resurfacing is the goal. On the other hand, if you wanted to resurface the patella, you have to know how to resurface the patella. You have to replicate the native patella, measure the patella, measure the components, minimum resection, because with a lot of resection, there is a risk of fracture, and assure the transfer patella truncated. You have to draw down the axis of the patella, and this is with the key wire here, with the white point here, to put the center of the patella and to avoid these anterior-posterior maltracking or lateral maltracking of the patella. It is very important to put your patella in the right place. Finally, not the final point, and what is the evidence now in 2020 of the type of prosthesis? What type of prosthesis which gives you the better results in knee alignment and better kinematics of the neck? There is no clear or notable clinical difference between cruciate retaining and posterior stabilized design. Patients have similar clinical outcome, and several studies have demonstrated similar for survivorship. Nevertheless, medial pivot design theoretically recreate more normal kinematic compared to cruciate retaining or posterior stabilized design, although an improvement in clinical outcomes has been suggested by some studies, but not clearly demonstrated. Patients do not prefer at the moment the pivot design in regard to a more normal feeling and increased stability that's close, although there is no clear evidence today at the increased stability in this design. Mid-term survivorship of medial pivot designs has been similar to other designs, but additional long-term data are still necessary. Since this concept came later, then we need more data to show on the long term it's better, like for uncemented hip, and before in the 70s and 80s we need with only cemented, and we have survivorship till 30 years, but now we do use only uncemented, but we have to have more long-term result of these pivot design arthroplasty. Given similar rates of patient satisfaction and component survivorship, the choice of component design should be based on the surgeon preferences, his familiarity, and cost of the implant in our environment. Last point, for the kinematic of uni knee. Uni knee has considerable advantages, including lower perioperative complications, morbidity, earlier care or recovery, and compared with total knee arthroplasty. The traditional stringent indication for uni knee have been called into question by reports. Extended indication based on diagnosis of anterior medial osteoarthritis of the knee and showed successful results. Both fixed or mobile bearing uni knee implants showed excellent clinical results and more than 20 years post-op, but continue experiencing distinct forms of long-term implant failure. But you have to be more trained for uni knee than total knee arthroplasty, I think, to have an appropriate patient selection and execution of surgical techniques. It's very important, the selection of the patient and execution of correct surgical techniques. Any malalignment of the PET, of the femoral component of the tibial plateau leads to a failure, and the execution of good cervical technique is paramount to optimizing the patient results in uni knee. Then you have done everything now, and what are your take-home messages? First point, to consider the pathoanatomy of osteoarthritis of your patient. Soft tissue, keep in mind, soft tissue are as most important in knee kinematics as bone morphology. The principle of the 3 axes of the knee to plan your 3 knee arthroplasty. Precise technique in resurfacing the patella to avoid any maltracking, lateral maltracking of the patella. Uni knee remain a good adoption in unicompartmental knee osteoarthritis. Finally, to achieve a good knee kinematics, combination of evidence-based techniques, well-documented prostheses are paramount to optimizing the patient's of the results and to meet your patient's expectation to bring it back almost normal. Thank you very much.
Thank you very much, sir, for this excellent talk. Your talk, sir, was evidence-based, very illustrative. I think everyone hearing to your talk now can understand all about the total knee replacement from your marvelous talk, sir. Thank you so much, sir.
Thank you. You're welcome.
Thank you, sir. Thank you. Now we are ready to have questions to Professor Sofiène Kallel. May I start with one question to you, sir?
Definitely, yes.
From your long experience, sir, how can I preoperatively determine if I have a patient with osteoarthritis of the knee and ligamentous laxity? How can I determine preoperatively that this patient will be a candidate for constrained knee or semi-constrained knee or just the straightforward ordinary knee? Is it possible to be determined preoperatively, sir?
Definitely, because if you have, there are some laxities that cannot give you the opportunity to have to put a regular knee arthroplasty. Mainly patients who had already pantad of the knee. Posterolateral corner is very important. You cannot put regular knee without have popliteal tendon, for example. You cannot. If you have popliteal tendon, it's in the knee, it's not anymore stable. You need minimum of stability. Cruciate retaining, the cruciate ligament, we can do regular total knee arthroplasty. But the peripheral, lateral collateral ligament, posterolateral, posteromedial angles are very important to the stability of the knee, and you cannot correct them only with a regular knee arthroplasty. You have to achieve more constrained knee arthroplasty.
Thank you so much, sir. Dr. Ahmed, we are ready with the questions. Dr. Ahmed Sheikh?
Yes, Prof. A question from one of the attendees. Can you please repeat the 3-axis technique?
The 3-axis technique, the most important one is, as you said, the paramount is the flexion extension axis, the femoropatellar axis, and the axis, the perpendicular axis that the tibia is turned around, which is almost 5 degrees of valgus of the distal femur and not exactly perpendicular to the mechanical axis, the functional axis of the knee.
Okay, another question.
I can give you, yes, sir?
Is the medial pivot design and the mobile bearing, are they similar or they are different?
No, they are different. Medial pivot and mobile plateau are different. Medial pivot, it means there is the principle on the medial part of the ball and the socket. It is constrained in the medial part. And the lateral part is unconstrained, almost unconstrained, and there is almost no flange in the medacta procedure. There is no very, very thin posterior flange. It is almost flat in the lateral part. But in the medial part, it is constrained. In the mobile resurfacing, you can have both plateau which are constrained, but it gives you more mobility in the rotation. It's not the same concept. There is the anterior posterior movement in the medial constraint, medial condyle, is the axis is more medial and the posterior lateral plateau goes anterior and the condyle goes posterior. In the mobile plateau, the lateral condyle in the same position, but it turns around the axis of the tibia. And in the medial constraint, it is the axis in the medial plateau. It's different. You have more flexibility in the medial constrained prosthesis.
Next
Another
question, Dr. Ahmed.
Yeah, how to deal with flexed knee to restore the axis?
Fixed.
He said flexed knee. I don't know exactly what does it mean. Flexed knee. Is it flexed flexion deformity? I don't know.
In difficult cases, if you cannot find you had in arthrodesis of the knee, for example, there are very difficult cases. It is very difficult to bring back the different axes, and you have to plan it. I use computer-assisted surgery today for these very difficult cases or very big deformities. I use computer-assisted, but computer-assisted should be used for people who have done already a lot of types of arthroplasty, because if you lose the computer midway of your surgery, you cannot stop.
Yeah.
Any other questions, Dr. Ahmed?
Any other question?
In genovalgum knee, what are the special considerations?
This is very interesting question, because in severe valgus, I am not sure that all these, because our course is basic course. It is not course, but it is not an advanced course. In very severe valgus knee, I think there is the knee initially is not normal today, because there is hypoplastic lateral condyle, and there is retraction, there is shrinking of the lateral posterolateral corner, and that's why to balance the soft tissue, we sometimes are obliged to use the pine crafting techniques or some techniques to modify a little bit the soft tissue to give a good alignment of the knee. These are very particular conditions. Yes, I do. But we are talking for regular osteoarthritis knee. Even the deformity is important, because that's why we said we have to have an idea about the pre-arthritic situation of the patient. How was the patient before becoming has pain or has discomfort or any problem with his knee? We have to imagine how was the patient before to plan how to bring him back to his normal function.
Another question about the deformities, how to deal with the recurvatum?
How to deal with the recurvatum? We have to deal with the recurvatum. There are two components in the recurvatum. It depends on the recurvatum. What is the origin of the recurvatum? The recurvatum is bone deformity, or it is soft tissue problem. Because in neurologic problem, this is another chapter, because the patient has a very big recurvatum, has to correct the soft tissue problem or the deformity first of all, or otherwise we have to plan to restore the anatomy normal before, or to put the prosthesis in the physiological position. What means? If you have a supracondylar fracture, for example, and you have displacement in recurvatum of the distal femur, then you have to put the prosthesis in the initial position, not to put the femur on the femur when he is in recurvatum situation. Then you have to put your femur in the position where he is more flexed to give the knee in correct position. That you have to separate in two situations. What is the soft tissue or bone deformity? Soft tissue, we have to solve the problem of soft tissue. The deformity, we have to manage the deformity. If pre-op osteotomy to bring back the knee in normal situation and then put a total prosthesis, or if you have recurvatum of bone deformity, which can be corrected by a new positioning of the prosthesis in a way that you will not have any recurvatum post-op, that you have to modify the position of the distal component of the femur. Right, we are not in discussing in in such situation, like we discussed in the talk.
From your experience, what do you think about the long-term outcomes of high flexion knee, total knee replacement?
Actually, it is not only my experience, but the data which is available, because the high flex knee has a very good outcome at the moment, because the high flex knee is a lot used in Asia, mainly because people are used to sit down and the kneel in our environment, because people are praying and they are using. But what is very important with high flex knee, if your patients come to you with osteoarthritic knee, with knee which doesn't go around more than 90 degrees, and he has the back 4, very degenerative knee, and very stiff, and there is contraction of the quadriceps. Even if you will put a high flex knee, you cannot recover your flexion of your knee. It's very important that you discuss with your patient. If the knee is soft tissue are normal, and you can have almost complete flexion of the knee. In this situation, when you put a high flex knee, you have good outcome. But if you go on a knee which is already stiff, and the patient cannot kneel or flex more than 90 degrees or 100 degrees, it is not with the high flex knee that you will have 140 or 150 degrees of flexion. You cannot have it, because the soft tissue are not normal. That's why we stress on the importance of the soft tissues around the knee. It is not only bone deformity that you have. The first take-home message in the first part, that the evaluation of the soft tissue is as much important than the bone.
Sir, if I can have a comment on your
yes.
This last question, from what I understand from you, sir, that the two main elements to have a stable and excellent knee replacement is, first, I have to respect the soft tissue balance. I have to restore the soft tissue balance. And second, I have to regain the axis of the knee. That's right, sir?
Mm-hmm. Yes.
Yeah, thank you. Okay, Dr. Ahmed?
Yeah.
The high flex,
Any
the
other
high
questions?
flex the high flex is modification of the posterior condyle with the better roll back, and you can flex more. Okay. Then the cut, the posterior cut, is more important, thicker. Okay. Then when you put a high flex knee, if the soft tissue are stiff and the patient had been praying for 10 years on a chair, and he wanted to put the prosthesis to come back and to kneel normally, it will be very difficult.
But what about the failure rate in the high flex knee? What about the failure rate? The wear rate is, I think it's much bigger in high flex knee than the ordinary knee, or what do you think, sir?
No, it's not much more higher, but it depends. You have to see that more the high flex knee. There are knees which are used mainly in Asian countries and in our environment.
Middle East, in the Middle East and Asia, yeah.
These 2 points modify the type of publication that have been done, because in these 2 areas we publish much more less than in Western countries. Okay. And the experienced center are less important. Then the cohort is not exactly the same. This is these points we have to understand when we compare results. Okay, we say this is a cohort coming from a country where the surgeon performed only 10 knee arthroplasties a year. He is doing high flex, for example, and this cohort is done by a surgeon who is doing 500 prostheses a year. Okay, but it is not high flex.
Yeah,
the result will be better in the other side, whatever the country is.
Yeah.
Okay.
Yeah.
That's why the last point I said, to achieve a good knee kinematic, the combination of evidence-based techniques, well-documented prosthesis. You have to know what is your prosthesis and your technique. It is very important to optimize your technique. But if you are doing for example, when there is a surgeon is doing 10 prostheses a year, this month he's doing Smith whatever, and the other one brand B, and 1 month later brand C. And he told me after 5 years he's collecting 50 knees and say, I'm doing a study about 50 knees with 10 years follow-up, and each knee is one type of knee, and the surgeon is doing only 10 knees. It is not regular homogeneous cohort.
Yes, sir. Thank you, sir. Dr. Ahmed, any other questions to Professor
Yeah,
Kallel?
a couple of questions. Question from Prof. Benha Corona. What's your management in cases of fractures if you fracture the patella during patelloplasty?
Unfortunately, I have done one. I have done an osteocentesis Prof. We have done tension band and fix, and we cemented, and the rehab program was a little bit lighter than the regular one in deflection, and the results of the patients, to be honest, wasn't very smart. I would say she had, I think, between 80 and 90 degree deflection or more. She can walk correctly. She doesn't have any problem in walking, but climbing stairs and kneeling is impossible for her.
A couple of questions about special consideration. One about the soft tissue. He asks about how to deal with case of generalized ligamentous laxity. And the other question about rheumatoid patients.
The first question is not complicated because when you have very big laxity, patients are likely to use very constrained prosthesis. But the second point about rheumatoid arthritis, we use only cemented knee. The question is very large. We use only cemented knee. We research the patella in the rheumatoid in all the cases, for example, because it's inflammatory disease and there is it will change with the time and they are always painful. There is almost synovectomy of all the synovial tissues all around. It depends on the amount of deformity of rheumatoid arthritis, because there is people coming early, some others are coming very late with bone stock, which is very poor, and soft tissue, very inflammatory, and this case was very constrained knee. We use the Zimmer one with the big cam in the middle. If there is no peripheral laxity, but if there is damage in the lateral collateral ligament or posterolateral corner, it will be very constraining knee.
One technical question about the transverse axis versus the epicondylar axis. You mentioned that we should align with the transverse axis. He asks about how can we do this?
Yeah, when you it is with the aimer of the it is with the center. You use your cautery to see the ball or posterior condyle. And it is not very difficult. You find when you put your hand on the posterior condyle, you can see your it's easier. It's much more posterior and a little bit higher this flex extension axis, not the epicondylar, because most of people are using this epicondylar axis and do systematically 3 degrees of external rotation now, because when you fit your you have the femoral condyle here, for example, and you put your prosthesis laterally. You can draw it with your cautery, and you will see exactly where your prosthesis will fit exactly, and the thickness when you plan your total knee on the X-ray on pre-op on lateral view. You know exactly where the prosthesis will be it, and you will see it in perioperative. You can match exactly what is your planning and your template you have done in your work.
One last comment. It's about the
Yes.
post-operative rehabilitation. He asked about, should we focus on some individualized special program for patients to have a better results, or it's something like a universal rehabilitation program for all patients?
No. There is no universal program, because it depends on the status of the soft tissue that you have. There are some patients who have already pre-op very good soft tissue environment with no stiffness, and they have good mechanical access. The osteoarthritis is not very important. Some of them will finish their program after 6 weeks only, and some of them, I have seen even some people are coming to Tunisia from abroad and coming back home without any particular program, but they have very good soft tissue environment. They have very good results. On the other hand, if you have stiff knee pre-op, very severe osteoarthritis, you have to follow up very carefully post-op. You have strict program. It could be at least 3 times a week, if it is more, to encourage your patient to move. It is functional surgery. Patient shouldn't be in bed after surgery. At home, they have to sit, to walk, and to go around in your home in post-op, and not stay in the bed. No bed after knee surgery. No bed after knee surgery. They have to walk, and they have to do their program closely if they have stiff knee and major osteoarthritis pre-op, and the program will last us 2 to 3 months. If they have very good soft tissue with mild malalignment pre-op, the program will be shorter and will be easier and less painful, mainly. Because there is another point we didn't discuss, because it is not the message of this talk, is how to manage the pain in post-op. Pain is the key. Pain is the key in the program, much more than the rehab program.
Any other question, Dr. Ahmed, to Professor Sofiène?
One last question about doing bilateral knee on the same day.
Bilateral knee in the same day is a program. It's a roadmap. It is not technique. Bilateral knee, you need to see the patient at least 3 weeks before surgery. You need to prepare the blood for this patient's autologous transfusion. You need to have tranexamic acid, which is available. You have to prepare a rehab program for the patient and prepare the patient pre-op with the whole team, the surgeon, the nurses, the rehab guys, and they should have simulation of program before surgery, and they can have bilateral. We rarely use that, and we rarely recommend that in our environment if it is not everything which is prepared. Bilateral knee, it's a surgery which should be reserved to specialized center with specialized team, where the education and they should have minimum level of education for the patient and for the team, which is prepared for that. Anesthesiologist, surgeon, rehabilitation, and nurses, and lab. If all these elements, you don't have them, and you don't have time to prepare your patient, because we have in our environment a lot of patients coming from other cities, sometimes in other countries, you cannot do bilateral in such conditions. Each patient should be well prepared for this type of patient.